Good evening, everyone, and thank you for joining us. My name is Adrienne, and I'm a product specialist here at OCULUS. Welcome to our clinical webcast titled Specialty Contact Lens Troubleshooting. Please remember you have a text box on your GoToWebinar screen where you can enter questions. Enter your questions at any time, and we'll discuss them at the end of tonight's webcast. I'm really excited to introduce tonight's speaker, Dr. Cheryl Chapman. Dr. Chapman is a graduate of the University of Houston College of Optometry and currently works in private practice in Gretna, Nebraska. She has instituted a full-scope myopia management clinic within her practice and works tirelessly at spreading myopia management knowledge. In addition to working one-on-one with doctors to implement practice protocols, she lectures within the optometric community as well as to local pediatricians and ophthalmologists. Serving as an adjunct assistant professor at the University of the Incarnate Word Rosenberg School of Optometry, Dr. Chapman also enjoys working closely in training fourth-year extern students in current myopia management strategies. And now I will turn it over to Dr. Chapman.
Thank you so much. I'm very, very pleased to be here tonight because orthokeratology and myopia management in general is probably one of my greatest passions. So I know that this is a highly anticipated subject matter for a lot of doctors who are looking to get started, and sometimes Ortho-K can seem a little bit intimidating. So hopefully tonight we will be able to kind of demystify some of the common pitfalls that you might run into with Ortho-K. And a lot of the stuff that you're going to see tonight will be based off of Pentacam scans, but you'll see some MedMont topographies as well. And I'll try and walk you through things so that you can maybe kind of orient yourself a little bit with what you're looking at. But one thing I always want to start off when I'm talking to my student externs and we're talking about changes that we might make in a lens, or if a lens is just not seeming to fit quite right, I always caution them, let's not make a change too quickly. If we're only, doing the, first follow-up after their first night of wear, or if we're only a month in, if we're only a week in, and the lens looks like it maybe doesn't have as much treatment as expected, or it maybe looks like it's trying to decenter a little bit. I think it's always really good to remember before you do any sort of troubleshooting whatsoever is to make sure that you've given that lens proper time to have its full treatment effect before you make any changes. You might find yourself in a situation where you're really just kind of chasing your tail. You need to know what the full treatment of that lens is before you can make the correct modifications on it. Now, keeping that in mind, there could be a few exceptions with that. If you see something that is a concern to the corneal health, if it's causing a corneal abrasion or whatnot, or some other very obvious issue, like definitely there are situations where you could change it sooner. But barring those exceptions, you should really give yourself a full month in a mold before you decide to make a change on that corneal mold. So let's go ahead and kind of get to more of the fun stuff here. So what I have right here for you is an example of a Pentacam scan where I'm doing a comparison of my pre-treatment map, which would be this one right here in the center. Hopefully you can see my cursor, versus our post-treatment map. And so you can see the dates on here. This particular scan was taken in September. The pre-treatment map was from about 4 months prior. And then what we have over here on the very right, that's our difference map. Another term for difference map that you will frequently hear is subtractive map. So if people say, make sure you're looking at the subtractive map or make sure you're looking at the difference map, those two terms mean the same thing. And when we're doing our follow-up visits, there are a couple of different types of subtractive maps that we want to be looking at. The one that I have pulled up right here is the axial subtractive map. And when you look at that, what you really are getting in terms of information is you're getting the amount of power change at the apex of the cornea. And that's really useful if you have a patient who was a -3 pre-treatment and you really want their power to be like overplussed by about 1 diopter in the morning, then you're hoping that you would get about a -4 change here. So that axial map is the one that you want to be looking at when you know how much power you have changed. Now our next subtractive map would be the tangential subtractive map. And when you're looking at the tangential subtractive map, that's really telling you the centration of the lens fit. It's also telling you the size of your treatment zone. So a lot of times people will reference the red ring. So the map all the way to the right here is the difference between our pre-treatment and post-treatment map. And it tells you the amount of change that you have tangentially, and that red power ring is what people will often refer to as, is it inside the pupil zone or outside the pupil zone? And a general belief is that for good myopia management, you need at least a portion of that red ring to be within your pupillary margins in order to simulate or stimulate that peripheral myopic defocus and those aberrations that cause that stop signal for axial elongation. All right, so we'll move on to the next slide here. So we're going to kind of walk through now some of the pitfalls or problems that you might see with lens fit, whether the lens is decentering upwards or downwards or laterally. In this particular scan right here, it's an example of a superior decentration. So you can see that red ring and that treatment zone, they're positioned a little bit superiorly relative to the overall cornea. And then down here we have a picture of a lens that's fitting just too high. And people like to often refer to that superior decentration as a smiley face. And that's because relative to like where your pupillary margins are, the bottom edge of that ring kind of creates a little smile within the pupillary zone. And when we see a smiley face or a superior decentration, really what that means almost always is that your lens is fitting too flat. And when we have a lens that's fitting too flat, the best thing that we can do is to try to steepen that lens a little bit or to try and increase the sagittal depth because it just has too little sagittal depth. So one thing that's really important, a concept that's really important to understand is when you are changing the fit of an orthokeratology lens, you are not changing the base curve of that lens. Base curve would refer to changing like the central curvature of radius. What we're really wanting to do is we're wanting to change the alignment curves. Another way that you can increase sagittal depth or steepen a lens sometimes is to increase the overall diameter of that lens. But I would say your first move should always be to work with your alignment curves. That should always be your number one choice. Changing the overall diameter is something that you could do secondarily if changing the alignment curves is not working for you. So let's look at this slide right here. When I said you don't want to change the base curve of the lens, I mean you don't want to change this curve. Why? Because changing the base curve changes the amount of treatment that you have over the apex of the cornea, but it does not affect your fit. Think of the term alignment curve. Alignment means how does it align with the cornea? And this part of this curve right here, it's kind of showing you like a peripheral power curve of this lens. This part is the alignment zone, and that's the part that's kind of helping sort of guide that lens, kind of tell that lens where to sit on the cornea. And you're really trying to match the peripheral regions of the cornea out here to get that centration. So let's say I need to modify a lens. You will see in the New Wave software here, this little area called modification area. I would say that the New Wave software is really quite intuitive. So when you click on this little icon right here, it will bring you to this little screen. And so you'll see there's different modifications that you can make. Again, very intuitive, very simple. When you click on alignment zone, these little two boxes will pop up. And you can either choose to increase your sagittal depth or decrease your sagittal depth based on whether you need to make your lens steeper or flatter. You will also see here, you can choose how many microns you want to change it. The default that always comes up is 5, but really, quite frankly, you usually want to change a lens by at least 10 microns to have any meaningful difference. And I think some practitioners would argue even more than that, maybe 15 or 20 microns. You can see here also that you can choose to change, to make this change in all mode. When you do it in all mode, it'll change your alignment curve all the way around that lens. If you, for some reason, only want to change the alignment curve on the nasal or maybe the horizontal meridian altogether, then you can switch to either half or 1/4 mode and make that change nasal, and then do it all over again and do it for temporal. Okay, so we're going to move on to one of the most common things that you will see, frowny face. If you are fitting lenses a little bit too steep, then you will get kind of that inferior decentration. And if you have that, if you're kind of looking where that pupillary zone is again, kind of that edge of that peripheral power curve sort of creates a frown at the top of the pupillary margin. That's where that kind of gets its name. What you see in this example down here in this picture too is that this lens is fitting so incredibly off center that the edge here is actually lifting up. So this lens is has too much sagittal depth that causes that lens to ride low, and the change that you make is opposite. You want to decrease the sagittal depth. So again, going back to that wave modification tool, you would want to change the alignment zone to decrease the sagittal depth. All right, so here we've got a central island. I would say central islands are far less common, and typically you'll get a central island when the lens is just too steep. And if the lens is too steep, your hydraulic forces are really messed up. Normally we want a very, very thin tear film layer right at the apex, and then that reverse curve usually will have the more liquid or more of the tears to help pull those epithelial cells out to the side. But if you have a lens that has too much sag and it's actually kind of vaulting over the apex there, then that can actually cause the hydraulic forces to bring some of that epithelium into the center, causing this little island of tissue right in the center. And in fact, you can actually make somebody more myopic. And that's kind of what we do when we do hyperopic Ortho-K. We're trying to get that tissue to move towards the center. So that's very, very undesirable. It's important to know too that sometimes on topographical scans, particularly Placido-based topography. So remember, the Pentacam is Scheimpflug topography, which is totally independent of the tear film. But if you're doing a Placido-based topography, if you have central SPK, that can look like a central island on your topography. So whenever you see a central island, especially if you have Placido-based topography, you need to make sure you're putting sodium fluorescein in the eye. You need to make sure that you're looking at that cornea to rule out SPK. Because I would say a false central island on a Placido-based topographer is more common than a true central island in my experience. Okay, so how do you troubleshoot a true central island where the apex of the cornea is actually elevated rather than being pushed down? What we need to do typically is just decrease the sagittal depth of that lens. And again, you go into those wave modification tools and you select that you want to decrease the sagittal depth of the alignment curve. And again, usually by at least 10, maybe 15 or even 20 microns. Sometimes this is a situation where maybe decreasing the overall diameter is a better strategy. And the key here is to really look at the lens on the eye to figure out if your diameter's too big or too great. Sometimes these corneas are more oval in shape rather than completely round. And if you are measuring your horizontal visual iris diameter and you're getting one thing, sometimes if you measure actually more of a vertical visual iris diameter, you'll see that their cornea is much shorter vertically than it is horizontally. Well, if you have selected an overall diameter of your Ortho-K lens that is so big that it's actually landing on the limbus at that 12 o'clock and 6 o'clock position, that in and of itself can cause a lens to vault up and over the cornea a little bit. So that's a good rule of thumb. If you see a central island, to actually put the lens on the eye to confirm that your overall diameter of your lens is not too big in all meridians, both horizontal and vertical. Okay, so here we have highlighted nasal decentration, and I would say that generally nasal decentration is going to happen more commonly than lateral or than temporal lateral decentration. And I would also say that combating any sort of lateral decentration, whether nasal or temporal, is I think much more difficult than taking care of a smiley face or a frowny face topography. And the key is, I think, because it's more of a taper on one side of the cornea, where when this says flat nasal taper here, what that means is that the cornea on the nasal side flattens at a faster rate than it does in the other three quadrants of that cornea, whether superior, inferior, or temporal. And so what ends up happening is you end up having a lens that's fitting kind of tight in that region, which is causing a little bit of lens binding off center. And so that lens just really doesn't want to center up properly. And so a good way to try to fix this is to steepen that lens by flatten that lens because it is too steep. And so you would do that again by decreasing that sagittal depth. But what's really tricky too is sometimes it's not from a flat nasal taper. Sometimes you just have super tight upper lids, and everybody's upper lids are different. We know that the Asian population tends to have an even tighter upper tarsus, which can really cause that lens to decenter nasally. And I would say if you have a really, really tricky nasal decentration, reaching out to the consultants at WAVE can be very helpful for some of these cases, because there are some more advanced techniques that can sometimes be done, such as lifting the peripheral radius of that lens up and away from that peripheral cornea to try and get the lens to have even more interaction with the lid and have to interact with the center of the lens. Okay, and again, this is an example of troubleshooting that nasal decentration when you're trying to decrease the tightness of that lens. You would again loosen or flatten the alignment curves in order to reduce that sagittal depth. And just another example, hopefully this is starting to look familiar or maybe even a little bit redundant, and that's just how easy it really can be to work with the modification tool in WAVE. All you need to know is which direction to go. You click on those modification tools and you just kind of step through the process. Okay, now here is an example of temporal decentration, not nearly as common as nasal decentration. In this case, you get a little bit of a flat temporal taper, and the correct troubleshooting here is to actually try and loosen, to try and tighten the lens up. In this case, often the lens is a little bit too loose and has not enough sagittal depth. So again, you'll adjust the alignment curve. It is too flat, so you want to steepen it. So you increase the sagittal depth. And I'm trying to use terms sort of interchangeably so you hear it over and over again. To steepen a lens, you increase sagittal depth. To loosen a lens, you decrease sagittal depth. Okay, so let's kind of move on a little bit. We'll move on to the next part of the modification tools, and that would be the base curve. So remember again, when we want to adjust the fit, we're changing the alignment zone to change the alignment of the lens against the cornea. If you need to change treatment, that's when you're changing the base curve or the curvature of radius on the center of the lens. And so when you click on that, you will see two options come up. You can either steepen it or you can flatten it. And then it will ask you how much you want to steepen it or flatten it by. They make it very, very simple for you. This is in diopters. So you don't have to do any math. You just know, oh, okay, I have the patient coming in at 8 o'clock in the morning and they're measuring at like a negative 0.5. Well, my target for them was really a +1, so I'm gonna have to change this by a diopter and a half. So however much more you need them to go. And remember, steepening the base curve will actually decrease treatment because we're not pushing on the cornea as much or pushing on the tear film. We're not producing those hydraulic forces to have as much of a push force. And if we want to increase treatment, we will flatten it to get it to push those hydraulic forces down on the cornea a little bit more. Okay, so we'll give some examples of that here. Again, if the patient is undercorrected, they come in at 8 o'clock in the morning and they're measuring at a -0.50, you want to get a little bit more plus power in there. You need to flatten that base curve, and you'll see that again right there. And you just designate whatever amount you want to. So the rule of thumb here within the WAVE software is if you need to make a change of 1 diopter or less, flattening the base curve is the recommended move. But we do also have the ability to play with the reverse zone a little bit here. And the recommendation is to change it by about 10 or 12 microns if the undercorrection is more than a full diopter. I actually want to tab back to this one. You'll see that the reverse zone, you'll see that that modification tool is right there. Okay. Now, what if the patient is overtreated? They come back in and they're like a +3 and they are, 13 years old. They can't tolerate that much extra plus. Okay, so we want to back off a little bit. So you'll maybe want to steepen that base curve. You can see that modification right here, a very, very simple modification. You can also do it by adjusting the reverse zone as well. And please do note that adjusting the reverse zone there will decrease the size of the treatment zone a little bit. Okay, so I've kind of walked through some of the more basic modification tools that are available, but what I want to show you now is something that is maybe just a little bit higher level. It gets to be a little bit trickier because some of the modifications you can do within WAVE are really beyond what the modification tool bar that I already showed you can do. And what I'm going to show you here is how to deal with some residual astigmatism. WAVE is fantastic at working with astigmatism patients. However, sometimes, you've got these freeform designs and that's really, really great. However, sometimes you still have astigmatism when that patient comes back in. So there's really kind of two main ways that you can deal with this astigmatism. The first way is to create an oval treatment zone, which I have demonstrated here. If you look at this, you'll see it's really more oval or egg-shaped. It's not perfectly round like a lot of the treatment zones we're used to seeing. And in order to do that, you simply adjust the size of your treatment zone within the WAVE software differently in the vertical meridian than you do in the horizontal meridian. And I'm going to show you an example of that here shortly. Another way to do it, rather than adjusting the overall size of your treatment zone, is to adjust the amount of topographic demand in one meridian versus the other meridian. And I will kind of walk you through that here as we look at the WAVE software. Okay, so one thing to know is, well, which direction do I go? So I have this little key here on the side. If the patient has with the rule astigmatism, you want your oval treatment zone to be shorter vertically and longer horizontally. And the exact opposite is true for against the rule astigmatism, where you would want that treatment zone to be greater in the vertical and shorter in the horizontal. Now, the same rule of thumb can be applied to oblique astigmatism. You can do it along the 45 or the 135 axis if you need to. To orient you a little bit, if you're not super familiar with the WAVE software, this little white line here, it tells you where you're at, where you're working. And this is really important if you're doing modifications that are outside of this modification tool down here. So this white line corresponds to the nasal part of the lens that you're working on. Now, you can change. You can click anywhere on here to move your line around, even the oblique axis. And I think I have, yes, I have little circles that are going to come in here and help point out where I'm talking about. Now, if you want to work in just this meridian, you want to work in either 1/4 mode or 1/2 mode rather than all mode. If you are in all mode and you make a change, it will make the change all the way around. 1/4 mode will really kind of keep it in a smaller pie piece. 1/2 mode will make it just a little bit bigger pie piece. And you'll kind of get a feel for what you think is going to be, working best for you. But I think either one works fairly well. So in order to make a change in just this one meridian, you click on the ball right there that is orange that corresponds to the optic zone. And you'll see down here the optic zone is set at 6.7. And so what I wanted to do in this case was change this optic zone to be different than the one in the vertical meridian. And so if you click on that ball, then this little tool comes up with these arrows on it. And so you can, if you click on this left arrow, it will make everything shift this way just in this nasal meridian because that is where you're set. So then you want to make that exact same change over here on this side so that it does the temporal. Or you can, instead of having it clicked over here, you can click it over here and that would, and then that would make it say temporal over here. Whatever you have selected here is always going to be on the right-hand side of your screen over here. And then modification increments here is really useful too, because if you want to make a really small change, you can keep this at 1x. You also have the option to go 2x, 4x, or 8x. And the higher you go, just the faster it'll make your changes. And you can kind of play with it a little bit to see, how much it's changing and how much you want to go there. So I think the next screen will show us the other meridian of this same lens on this same patient. I will get there momentarily. I wanted to show you again, just to remind you what that looks like topographically, that it is an oval treatment zone. Okay, so this is the same lens and the vertical meridian is only 6.3. Remember, in the horizontal meridian, my treatment zone was 6.7. And now for this patient, I have the vertical meridian at 6.3. And I did that simply by using the modification tool to move that over. I'm sorry, I shouldn't say modification tool because really that refers to that by using this part of the WAVE software to move it over. Remember, with the rule, if we want to do something besides, I mentioned earlier, we could change the topographic demand. So if we wanted to do something besides creating an oval treatment zone, you can change the topographical demand. And when you do that, for with the rule, you'll change it you'll increase it in the vertical meridian. And if you've got against the rule astigmatism, you need to increase the topographical demand in the horizontal meridian. Again, you need to be in either 1/2 or 1/4 mode when you do this, and you need to be paying attention to where your hash mark is here. So now that this little white line is pointed down here at the inferior, you will see that you have the inferior part of the lens that you're working on over here. And again, you have this tool. When you raise or lower this ball, it will affect your topographical demand and your power over here. And you can watch how much power you're changing. And I would say it's not really a one-to-one relationship. So let's say I've got a diopter and a half of extra astigmatism. That doesn't necessarily mean that I want to change the topographical demand by a diopter and a half. Every cornea is different. Every cornea has different hysteresis and different, flexibility. So you do kind of have to play around with it a little bit and just see how much of a change it makes. I would say that sometimes I will make a little bit more of a change in topographical demand than what I have for residual cylinder. So maybe if I have a diopter and a half of residual cyl, maybe I will change that topographic demand by 2 diopters. But really, you just don't know until you do it. So sometimes you need to, go through more than one extra lens for some of those really hard fits. And that's why we charge more a lot of times on the tiered pricing that we do for really advanced fits and high cylinder and things like that, because we know we might have to make more lens changes. So that was a really high level troubleshooting, I would say, for a lot of doctors who haven't done a lot of that before. But hopefully you all were able to follow along. I know that we will have an opportunity for questions at the end. We can talk more about it, or you can email questions as well. I do have a couple other common pitfalls that I would like to talk about before we get to the question and answer period. And here I have just highlighted glare and flare. So sometimes glare and flare is a problem that is caused by a centration issue. Sometimes it's caused by the treatment zone size. And we kind of have to, look at the patient overall and see what are their needs. So if I have an 8-year-old patient that I'm starting in Ortho-K, a lot of times I'm fitting them in a really small treatment zone because I know that they're going to most likely get better myopia control from that. But as that patient gets older, and maybe they've turned 14 or 15 years old, and I know they're going to start learning how to drive soon, and I'm worried about them having glare and flare with nighttime driving, maybe I want to, adjust that treatment zone size. Or, I think it's pretty well understood too, if we have an adult patient and we're fitting them in Ortho-K, we will often start with a larger treatment zone size because we know that we're trying to avoid glare and flare with their nighttime driving, or patient activities. So if you've got an older kid who plays baseball or softball, a lot of times once they get old enough that they're playing those late games and they're playing them under the lights at night in those really nice stadiums that are have those huge lights, at the edges of the field, they will get a lot of glare and halos in those situations. So what you'll find often is that as patients age, their hobbies change, their sleeping hours change, what time they go to bed changes. All of that will maybe require some adjustments in things like the size of the treatment zone of their lens. And so here I've illustrated 2 different lens fits. One is very nicely centered and one is a little bit decentered. And so, when you're looking at this, that little black line shows us where the pupil is. So we still, in this bottom scan, the patient may have really decent endpoint acuity when they're reading on your chart, but they might subjectively have a lot of issues out in the real world with glare and flare because of all the extra aberrations that are coming into this eye from that red ring of power that is so far within that pupillary zone. Now, surprisingly, a fair number of patients who have topographies like this actually have no visual complaints. They're very, very happy. If the patient comes to you and they have a decentered treatment zone like this, but they're seeing well and they're completely happy, there's absolutely no reason to change that fit. Now, when you go to lecture and these doctors are showing their Ortho-K cases, a lot of times they're going to show you this beautiful, perfect topography on top because everyone likes to show a beautiful topography. But every Ortho-K doctor has topographies that look like this, that they leave like this because the patient is happy. In fact, there are some studies that have come out that suggest that perhaps some decentration of the treatment zone like this will actually improve the amount of myopia control that you're getting, because they're getting more spherical aberrations on the retina and they're getting more coma aberrations on the retina, positive coma aberrations. And interestingly, those positive coma aberrations and those spherical aberrations have been shown in some studies to be a stop signal for axial elongation. So definitely, if your patient looks like this, they're off center and they're happy and their vision's good and they're not having glare and flare, leave them be. There's no reason necessarily to change that. Okay, but let's say you do need to change that. So there are, or let's say you do have some glare and flare and you need to adjust that. We already know how to take care of the patient if their lens is off-centered either nasally or superior or inferior, but what if we just simply want to make the treatment zone a little bit bigger? Again, we've got the smaller treatment zone here, and on this part of the modification tool within the Wave software, if you click on the optic zone diameter, you will get the option to either increase it or decrease it, and how much you want to increase it or decrease it by. It will make that change in all mode. You don't have the option to make the change to the optic zone in the quarter step or the half step, like I did with our examples on the residual astigmatism, which is why I wanted to show you how to do that in a way that doesn't use this modification tool. Okay, so here you have, if you increase it, you just have an example of how it gets all the way outside of that black pupillary zone. And so this is more like Ortho-K for an adult. For kids, or when you really need myopia control, you need at least part of that peripheral power ring to be within their pupillary zone. Okay, so why might a patient come to you and not be functioning as well and not be seen as well? Does it always mean that the patient is progressing in their myopia? No, it might just be that they're losing treatment over time because the lens is getting old. We have an example of a lens here that's just kind of beat up. It's got deposits on it, it's got scratches on it. Lenses, these Ortho-K materials that we're using, they're plastic, and that plastic can warp over time. Simply handling the lens, cleaning it, removing it either with or without a plunger, all of that can cause the lens to warp over time. And if the lens becomes warped and the reverse curve isn't quite as pristine as it used to be, you may not have as good of hydraulic forces as you had when they began wearing that lens. So sometimes just simply reordering the lens with no parameter change will get the patient back on track. If there are deposits on the lens, that can interfere with those hydraulic forces as well. And again, lens handling, it's really important if your patient is warping a lens really early, like a lens, they really should get about a year out of a lens. And if the patients are warping their lenses before they're a year old, you really should kind of review their treatment protocol or their care and handling protocols and what they're doing with that lens when they're taking it out, putting it in, cleaning it, all of that. And plastic, it can kind of, excuse me, change composition over time, kind of shrink a little bit over time. That kind of goes along with the warpage. And a lot of doctors will feel like the fits just tend to start looking a little tight over time. But it could be that the patient's not seen as well because their myopia is progressing a little bit. If you have the ability to measure axial length, it is extremely easy to determine if that is what is happening. Okay, so let's talk a little bit here about abrasions. So there are a couple of things that can cause some abrasions on the cornea. If you see abrasions, we worry about that because that can set the patient up for a really adverse event. We always are doing everything we can to avoid microbial keratitis with these patients. And if you have staining on the cornea, you really want to pay attention to the location. So if you have a lens that has too much sagittal depth, it's too steep, you could have peripheral or central abrasions. And you would think, okay, well, why a central abrasion? Well, because if it is really too steep, they could have just stagnant tears in the center of the lens, too thick of a tear pool, and no oxygen to certain parts of the cornea. I would say more commonly, you're going to see central abrasions with too little sagittal depth, a lens that's too flat. Usually that's not going to be too big of a problem with a lot of our low to moderate myopic fits. But if you're really trying to remold somebody's cornea who's got a really high prescription, let's say they're a -8 or they're a -10, like you're really outside some of the like FDA approvals there. So you're really doing some off-label stuff, which is not necessarily a bad thing, but you do have to be more cautious with those fits. And some doctors will actually use the strategy of molding them in 2 different sets of molds. Like maybe you take them halfway with one lens, and then after they've responded to that lens, then you redesign another lens to bring them the rest of the way, so that you're not pushing on that cornea, so that you are able to still retain that 10 micron layer of tear film between the center of the lens and the apex of the cornea. And hopefully that makes sense. Okay, so again, I just kind of wanted to review a little bit here. If you have too much sagittal depth in a lens, or it's too steep, you want to decrease that sagittal depth by flattening the alignment curve. What does that look like? Okay, in this particular case, this is how the lens design was initially started on this patient. And if I want to flatten that alignment curve, when I make that modification, what that tear profile is going to look like then is this. Now this line right here is the 20 micron line. You'll see a little 20 here. So I did not change this fully by 20 microns. This one changed by about 15 microns. And that's, that's a pretty nice little change right there. You can also flatten the reverse curve if needed, or decrease the overall diameter. But again, I think your number one troubleshooting thing to do in the beginning is typically to work with the alignment curves. And again, changing, if you've got too little sagittal depth, click on alignment zone. If you want to increase that sagittal depth, you click on increase sag, you adjust how much you want to change it by, and you want to be in all mode if you want to do it all the way around the lens. If you wanted to steepen the reverse curve instead, you would click on the reverse curve, or you can change the overall diameter. And to change, I'm going to go back to our last slide. If you want to change the overall diameter of our lens, you'll see your overall diameter is up here in this corner. If you do that, you just want to always keep a close eye on the center thickness, because sometimes changes you make will change your center thickness, especially if you're changing the overall diameter. So just always keep an eye on that before you put in your final lens order to make sure that you have that sufficient center thickness. Okay, so lens binding. What is lens binding? Lens binding is when the lens will just kind of stick onto the cornea. So in this picture, we put a plunger on the lens to show that that lens is stuck onto the cornea well enough that when we let go of the plunger, it actually is still sticking onto the eye. And I think it's incredibly important when you are training your patients on insertion and removal techniques that you talk about lens binding as though it will happen to them, because most Ortho-K wearers will experience lens binding at some point in time. And you want to make sure that they understand that it's not a really bad thing, and to remain calm and how to deal with it without freaking out. Because if they're not expecting it and they try to take their lens off with a plunger and their eyeball feels like it's coming with the plunger, it can really freak them out. So as long as they know that it's super common and it will probably happen to them at some point in time, and to remain calm and how to deal with it, that's just gonna, make you look like more of an expert in their eyes. It's gonna keep them calm. They're gonna have more faith and more trust in you. Now, if a patient is experiencing lens binding all the time and it's really hard to get off, maybe your lens is too steep, and so you might want to consider decreasing the sagittal depth of that lens by adjusting your alignment curve. But if it is minimal and infrequent lens binding, then it typically is not a big deal. Okay, so just kind of the, some more of the same. Hopefully you're all feeling like this is starting to become repetitive, and you're gonna go to your offices tomorrow and you're just gonna feel like you can troubleshoot pretty much anything that comes into your chair. Okay, and then one more thing I wanted to say before we kind of start to wrap this up here, is that when you're looking at a lens or you're looking at a patient and you're thinking, okay, I'm going to fit this patient in Ortho-K and I want to figure out what to fit them in. Do I want to do, a software design lens like Wave? Do I want it to be a freeform lens design? What level should I bill for this? Is it going to be, a hard thing? Every time you look at a potential Ortho-K patient, you should look at the elevation topographical map. And this is the first time I've mentioned the elevation map tonight. I know we spent some time talking about the subtractive maps for both axial and tangential, but always look at your elevation map as well. So right now we're looking at a Pentacam map that shows us elevation where the blue area is where the lens is a little bit, where the anterior surface of the cornea is a little bit steeper. These are the steepest points of this patient's cornea. And that's a little opposite of how we often think of, when we look at axial maps, the red parts are the steep parts, right? So right here, we're steepest here, and we're flatter on this horizontal meridian. But look at the difference here, plus 20, minus 34. This is a very toric cornea. So in a situation like this, you really ought to have the patient at the very least in a bitoric lens design, or even tri or quadrant specific design. So a freeform design for sure, you're like totally, you're even more specific than quadrant specific. And so you can handle pretty much any sort of weird elevation stuff with the Wave freeform design. So that's all of the slides that I have tonight. I'd love to take some questions. I think we have plenty of time left. We're still under an hour. What do we have we had any good questions come in?
Yeah, thank you so much, Dr. Chapman. That was such an insightful presentation. To the audience, I just want to remind you that on your GoToWebinar screen, you can still enter questions. If you missed any part of the webinar and you want to watch it again, possibly, you will receive a link with the recording in the next week or so. I do have a few questions from the audience here. Let's see. We have someone asking, would a freeform design with flatter alignment on the nasal side only be helpful in nasal decentration?
Yes, I believe so. That's a really wonderful question. When I was creating this lecture tonight, I was trying to keep things more basic so as to not overwhelm the audience, because I wasn't really sure the level, like what the attendees have in terms of their experience. But I have done that myself, where I will do a change only in that nasal quadrant for nasal decentration. And I have found it to work. Quite nicely. So I would say that I actually do that personally more often than I change the whole horizontal meridian.
Okay, great. Let's see. Do you ever recommend Ortho-K for adults? Are there certain scenarios where Ortho-K would be better than, say, LASIK or soft contact lenses? Do you have a certain, any recommendations for that?
Yeah, so I like that question a lot. I know some doctors really only want to do Ortho-K with children. I really like doing Ortho-K with adults as well. But there are some main differences that you have to be considering when you're doing adult Ortho-K. One is know that your adult Ortho-K patients are typically a lot pickier than children Ortho-K patients. So you have to be willing to manage their personalities a little bit more. They get really fussy sometimes about any sort of halos and glare. They get kind of fussy about residual cylinder, and they sometimes have much more demanding visual needs when it comes to driving duties, if they've got kids where they're carting them around at night, or driving home a little bit later sometimes because they, maybe they're coming home from a trip or something like that. So you have to understand those personality differences. And then you also have to be thoughtful of the age of that adult. I will typically, if I've got an adult patient that's like, 20s or 30s, then you're really pretty safe doing a nice large treatment zone. If you go too large with your treatment zone, that can make your alignment zone smaller, which can cause some decentration issues. So you want to be mindful of that. But generally, you do want to keep that peripheral power ring outside of that pupillary margin. Now, if you've got a patient that's older, if they're 40s or 50s, or even beyond that, you need to also keep in mind that they've got issues that need to be dealt with regards to their reading power. So then in that case, you might want to keep that peripheral power ring a little bit smaller than their pupillary margin so that you get that multifocal effect. But then if it affects their distance vision, with glare and halos, then that's a problem. So if you're approaching that conversation with an adult patient who's over age 40, you need to set those expectations properly, and you need to talk about it to them in the same way that you might with multifocal contact, like soft contact lenses. Like, tell them you can't always do everything, or that it might take more tries to get it right. So sometimes we end up doing sort of a modified monovision, or sometimes I end up having the patient wear the right lens one night and the left lens another night. And that'll give them what they need for their distance vision and their near vision. Or maybe sometimes you have one eye with a larger treatment zone than the other eye. So yeah, there's some ways to do it, but you definitely have to keep in mind that the conversation is sometimes different, setting the expectations is different, and sometimes managing the outcomes can be a lot more chair time than it is with the younger patients.
Right.
The second part of that question, I think, was asking about LASIK and soft contacts. So one thing to keep in mind is a lot of adult patients will drop out of soft contact lens wear because of dry eye. And sometimes I don't want those patients to go for LASIK because of their dry eye, and also because they're going to be back in glasses by age 40. So sometimes Ortho-K is a really fantastic option for those patients because dry eye is not a contraindication for orthokeratology. In fact, a lot of those patients do really quite well because they get to have their eyes closed while the lens is on their eye. So those are all things to kind of keep in mind.
Oh yeah, those are really great points. Okay, we have another question here. You mentioned the false central island caused by SPK. Do you have to discontinue wear temporarily to treat this?
That's a wonderful question. I would say no. You just need to figure out what's going on to cause it. So there have been instances where I will see some central SPK after the first night of wear, and that's the only time I ever see it. And it's just because it was such an abrupt change to the cornea, and that lens was just sitting a little closer than maybe it should have for that first night. But after that first night, the cornea has changed enough that it's not really an issue anymore. And sometimes it's just a matter of making sure that you're talking to the patient about their care instructions. Like, are they putting that drop in the bowl of the lens before they inserted it on their eye? Or when they're inserting their lens onto the eye, are they pushing it onto their eye? They should not push it onto their eye and really mush it down, because that can create an issue as well. So no, you don't necessarily need to always discontinue it. Now, if you're really concerned that central SPK is so bad that it could cause an abrasion, you might need to reevaluate that. But I don't think I've ever actually discontinued wear because of central SPK that was causing a central island. The one slide that I had that did show that central abrasion, that was actually an Ortho-K patient who had developed keratoconus. And we did discontinue their Orthokeratology wear, and they ended up doing cross-linking, and they're doing quite well.
Well, that's all the time we have for tonight. Thank you to everyone for watching and sending your questions in. And thank you so much, Dr. Chapman. We really appreciate your insight and expertise. Do you have any last words?
Yeah, I would really just like to thank all of the attendees for coming tonight. And I would also like to thank OCULUS, Pentacam Wave. It's companies like you who are supporting the doctors to help us bring such new and innovative treatments to our patients. And so thank you very much for hosting this tonight.
All right. On behalf of OCULUS, everyone have a great night. Thank you.
Thank you.
Okay. Bye.